talk. Formal introduction. Good evening to all of you to the weekly huddle. My name is Anup Agrawal. Lot of the attendees know me. I am an interventional cardiologist at Care Hospital, Hyderabad. I'm joined today by my colleague and co-host for the huddle, Praneeth Polamuri. So the huddle, basically, it's an audience level interactive session where we discuss a variety of things. And most of our discussion is focused around healthcare. We typically pick a particular topic or a clinical case. In this case, we have both. And we restrict our discussion particular to that so that there aren't much of what if this happens. We try to restrict to that particular topic and the case that we are discussing. Otherwise, the session goes on and on. The basic premise of the huddle is to bring our casual hallway discussions to a more organized platform like this one and share our ideas. While we do want to talk about science, the huddle basically aims to bring out our practice patterns and understand the rationale of what makes us take a particular decision. This huddle is hosted every week on Wednesday at 7:30, that is today. This is our 22nd session, so we have been doing it for about 5 months now. Today's session is on hypertrophic cardiomyopathy. Particularly, we are talking about the indications of ICD, and that is why you see some of our guests with that particular expertise. To facilitate the discussion today, we have few guests. I'll be introducing you. While today's guests are experts on the topic being discussed, the huddle is not a speaker and an audience model, but rather an audience level interaction, which means that any of the attendees, please raise your hands if you have any thought, or you can unmute yourself to give your input. As a courtesy that you should wait for others to finish their thoughts before you unmute yourself. So with this introduction, let me introduce three guests for today. We have Dr. Hygriv Rao. He had joined us previously as well. He is a cardiologist and an electrophysiologist at KIMS Hospital, Hyderabad. Dr. Johann, he is our in-house cardiologist, and he is the director for cardiac radiology, like CT, MRI, stress, those kind of things. He is also at Care Hospital. Dr. Priya, she is joining us from all the way from Chennai, and she is a preventive cardiologist. She has done a lot of work in hypertrophic cardiomyopathy, so we'll share her ideas as well. So with this introduction, let me hand the session to Praneeth. So I will brief the audience about how this started. Typically, most of these sessions, we get the idea from our own clinical cases. So Praneeth asked me about this case 2 weeks ago. We were just casually discussing. And then we thought that might well discuss this case on Huddle. So Praneeth, if you could just brief us about the case, literally the same way how you briefed me 2 weeks ago. And then we will ask the audience about how they would go around with this case. So Praneeth, on to you.
Yeah, so good evening, everyone. So this case was actually a consult from one of the critical care team. So this patient got admitted for COVID pneumonia, and while he was being treated for COVID pneumonia, in his background, he was diagnosed to be having hypertrophic, and he was on some treatment. So essentially, they called for a consult and see and help us whether anything else to be done, essentially talking whether patient needs an ICD or not. So I let him try to take some history and all. So he currently is 62 years, recently got is staying in Hyderabad. Family history, which I try to poke into, his family or at least siblings are totally 8, 3, 5 male. There is there is a strong family history of coronary artery disease. 3 of his elder brothers had coronary artery disease, and significant one history consanguinity and consanguineous marriage. There was a history of so-called sudden cardiac death at 13 years. A boy, 13-year-old boy, died 10 years, which there is known. And there is a big family. From his point of view, he is not. He doesn't have any symptoms, and he was aware of the coronary artery history, and he got himself evaluated at Mumbai while he was working, underwent angiogram which showed insignificant obstructive coronary artery disease, or he's on medical management. Immediately even was getting treated for hypertrophic cardiomyopathy. By the way, it is non-obstructive hypertrophic cardiomyopathy, and ECG also is suggestive of an apical HCM with that Gucci pattern. So this was the thing with a family history of coronary artery disease, and he's the only person or the index case that has a history of hypertrophic cardiomyopathy. None of the other family members have been tested, don't know about their status, and one probable sudden cardiac death in the second generation in the consanguineous marriage. How do we approach is what was the question that I asked Anup, and probably the same question is there to the audience today. And any other information which is needed, I can chip in. So over to you, Anup.
So Praneet, just to make sure, this guy does not have a history of syncope, correct?
No.
Okay, he's 60-some-year-old. His only issue is COVID right now. Otherwise,
Yeah.
all right.
Yes.
And this is a Yamaguchi apical HCM. This is not your classic asymmetric septal hypertrophy, correct?
Yes.
Right. And otherwise, he's asymptomatic. He's otherwise feeling fine, and there is only concern of family history. And that index case is not diagnosed with HCM. Is that right? That 13-year boy was not diagnosed with HCM. It's a sudden cardiac death.
Yes, presumably sudden cardiac death.
Okay. All right. Perfect. So I think with this clinical information, let us open for discussion. If anybody has any running thoughts, they can raise their hands or unmute. Else I will directly ask our guests to weigh in about how they would go for this particular case. So let me start with the clinical work of it. Dr. Hygriv, I'm unmuting you. You heard the case. If you need any other information, you can ask us. How would you approach this case? The basic question is pretty straightforward. Does this patient need an ICD or not?
Yeah, it's a very, what I should say, practically, as you rightly started off saying, that a corridor kind of question that often comes up with when you see a consult like this. Now, this is a man, when I see hypertrophic cardiomyopathy, I am very keenly noticing, listening to what is the age right from the age of the patient. The moment you have a person who is 60, 45, 40 plus, and especially 60 something, 60 plus, am I right? 60 years, right? Patient's age. Now, 62 years age. So the antenna for sudden cardiac death as such comes down quite a bit. On top of it, now we have a 62-year-old man incidentally detected to be hypertrophic cardiomyopathy. That means we are not sure he ever had any evaluation before. It was COVID that brought him to the hospital, and an echocardiogram done during a routine workup just brought out concentric LVH. It is not very clear about the there's no mention. Is there, we need more details, like was there SAM, or was there asymmetric hypertrophy, or was it just a concentric uniform hypertrophy? That is only to...
So sir,
go ahead.
Sir, just to interrupt you here. So this patient was admitted. He had a previous diagnosis of HCM. We did not make the diagnosis. He already had a diagnosis of HCM made. And it's a apical variant. It is not a asymmetric hypertrophy. He just has a apical HCM and ECG conforming to that. So that diagnosis was made a few years ago. We did not make that diagnosis.
Great. So the prognosis outcomes of apical HCM are no less severe than the classical HCM with respect to sudden cardiac death and other things. Now, this kind of patient, now if you look at, now that part about the diagnosis is clear. Now, when you look at hypertrophic cardiomyopathy, there are actually 4 important variants that you look for. Now, one is the presentation of syncope. The second is the age, and the third is the thickness of the thickest area in the hypertrophy, whatever you are wanting to say. And typically it's IVS, and whether it is 3 centimeters or more. And the fourth one is exercise-induced. This is the least important of all, actually. The exercise-induced syncope or arrhythmias. And a non-sustained ventricular, the minor things are non-sustained ventricular tachycardia. If you notice, if there are ectopics in the ECG, you look for a non-sustained ventricular tachycardia on the Holter. Now, this is a gentleman, a symptomatic apical variant of hypertrophy, 60 years and more of age, and he is not having any symptoms whatsoever with regard to arrhythmias, either atrial fibrillation or ventricular tachycardia, which are two important arrhythmias of HCM. And then there is, apart from a family history of a remote relative having a sudden cardiac death at the age of 13, which is really significant. But that apart, none of them actually pertain to this one. So I would certainly have a very low, in other words, reason to consider ICD in this patient per se, as such, with the clinical material available to me.
Perfect. Thank you so much, sir. Before I ask my other guests to weigh in, let me just get some insight of what my audience would do. And again, this is just trying to understand what we all think and what makes us think, like our rationale, not particularly what the guidelines say, because many of the times we don't translate it. So I'm just going to pick some names and see if you have any thoughts. Dr. Praveen Nagula, I'm unmuting you. You heard the case. How would you? Do you think this guy needs ICD? Would you need some more workup, or you agree with Dr. Hygriv that we don't need to do anything?
Sir, considering the patient having Yamaguchi syndrome, now whether what you call the siblings or the other family members have been affected or not, usually they say that sometimes Yamaguchi syndrome can be missed on the usual echo. We need a cardiac MRI sometimes. So I would consider the screening of the patients and see whether the other family members have been affected or not. And I would be taking more detailed history of whether there are any previously pre-syncopal episodes and re-evaluate the patient, sir. If still there is negative history, then I would go with that patient is having at a low risk and does not consider keeping an ICD.
So Praneeth, some question about patient's history. Any syncope, anything, because that would help Dr. Praveen to make a decision.
So, no significant history. I tried my level best to poke him, but he never complained any complaints of pre-syncope, any giddiness or anything. And even in the family history, there is none of these things other than that boy that I mentioned.
And then the family screening we have to do, that we haven't done yet, right?
Yes, they didn't know. Only he is having this diagnosis, and unfortunately, nobody has told him that this could be running in families. So this is the first time that he's hearing that HCM can be familial or can be seen in families. He's aware of coronary artery disease, but not HCM.
Perfect. All right. Let me pick up some other names. And again, any name I'm picking, I'm just trying to understand the thought process of yours. We are not looking at whose answer is right or wrong. So let's see. Dr. Hari Kiran, I'm unmuting you. You heard the clinical story. If you need any more information, please let us know. What would be your thought for this case?
Yeah, good evening, sir.
Please go ahead.
Hello. Yeah,
yes,
good evening.
Please go ahead. Please go ahead.
Hello, sir. That is regarding the same as Praveen Nagula sir said. I was just probing into the history more, and then if still it is negative, the same line of management. I mean.
Okay. So the history we have poked already. History, there is nothing. There is no syncope unless you put him on TMT, which let me ask Dr. Chandramukhi. I don't know if Dr. Chandramukhi heard this story. Ma'am, would you put this patient on TMT? Patient with a history of apical HCM, asymptomatic. Would you put this patient on TMT to identify ICD or not?
Hello.
Yes, ma'am. Please go ahead.
Yeah, if we can do treadmill in this case to find out any arrhythmogenic substrate. And one more thing I will like to add is that many times patients with ECG changes of hypertrophic cardiomyopathy, especially deep T inversions, we see many cases who undergo coronary angiogram to rule out coronary artery disease, because as soon as we see the ECG changes, many people tend to rule out the coronary artery disease. And in many cases, these patients will have TROP-I positive when they come with chest pain and ECG changes, deep inversions, TROP-I positive, angiogram is done and coronary artery disease is ruled out. So it is really important to do a detailed echocardiogram to rule out hypertrophic cardiomyopathy, especially in patients who have typical ECG of apical hypertrophic cardiomyopathy with deep inversions. So other members, other family members who were diagnosed to have coronary artery disease, it is a possibility that there may be substrate in other family members also. So we have to rule out the presence of hypertrophic cardiomyopathy in other family members. And in this patient, we can do treadmill to rule out arrhythmias. Also, if there are we need to do a Holter monitoring to rule out any, as sir has already pointed out, to rule out any ill-sustained or non-sustained VT. But definitely in this case, it will be a low threshold for ICD. ICD is not indicated in this case because this patient is not having any of the high-risk features. And in I would like to say that many cases with apical hypertrophic cardiomyopathy, I feel that this is the most benign substrate of the hypertrophic cardiomyopathy because it is apical involvement. They don't have any LVOT obstruction, and many cases they don't have any arrhythmias also, unless and until like few cases where we will have these presentations. Thank you.
Perfect. Thank you so much, ma'am. I'm just gonna take input from few others and then we'll go to my guests. So Dr. Vikas Reddy, I'm unmuting you. You heard the clinical case. How would you go about with this patient?
Yes, sir. Good evening, sir. Sir, what maximum left ventricle LV thickness on echo, sir? Is it more than 30 mm?
Okay, so this is an apical HCM, right? This is not asymmetric hypertrophy. So we are only going to measure the apex, not the septum. Septum is not thickened at all. Praneeth, do you remember what is the apical diameter on echo for this patient?
It was a screening echo which I did, Anup, so I could not take the measurements.
Okay, so the apical HCM, we don't know the thickness, and truly speaking, we can talk about it, how much thickness of the apical HCM matters in these kind of cases. So that information we don't have yet.
Yes, sir. In this, only the positive finding is the list of second cut. There is only one factor that is indicative of ICD, sir. We can subject the patient to cardiac MRI, and if there is any LG of more than 15%, then we can consider. Otherwise, as of now, there is no indication for ICD.
Perfect, thank you. So cardiac MRI is one thing that we can certainly think of. Dr. Prithvi, any further insight of what you would do for this case?
No, the same, sir. As everyone has told, same thing, sir.
Okay. Dr. Vijaya Lakshmi, anything that you would add? I have unmuted you.
I'd ask for a cardiac MRI, sir.
Ask for cardiac MRI. Okay. There is lot of love for cardiac MRI. There is no love for genetics. Dr. Priya, I'm going to bring you in here. This is a clinical case in front of you. There is a family history. 13-year-old boy died. Yeah. And yes, this guy is 62, so he has already passed that so-called high-risk phase. But can we leave him? Are you confident to leave him, or you think we should do something?
Thanks for passing it on to me, Anup. So a quick question. There was some voice break when it was being presented. So this 13-year-old boy, how was he related to our patient?
Praneeth, the relation of 13-year-old boy, huh?
The index patient's sister's son.
Okay, so that's his second degree. Okay. And does our patient have children of his own?
Son and a daughter.
And any history in them? Anything at all?
No, ma'am.
Nothing, is it? Okay. Yeah, I think so, as was pointed out by Hygriv and the other participants. So directly there is not a clear indication for ICD, but definitely I think evaluating him further with other investigations like the PMT stress test or the MRI might add more value, as well as the Holter. But the genetic testing part of it, yes. So a detailed 3-generation family history needs to be taken if it can be documented, nothing like it. So of course, as you pointed out while interrogating him, there's nothing much that's coming out except 13-year-old who died suddenly. But any other information of how that child died? Was it related to any triggers?
No, no, ma'am.
Nothing at all. No particular arrhythmogenic triggers or anything, is it?
No.
So what needs to be done is, of course, he being the maternal uncle of that child might not have that much information, but the siblings of this individual would, if they're willing for clinical screening, that might be a good idea to do that. But cascade genetic testing. But first question is, are we going to subject him for a genetic test? So given the fact that HCM reveals, genetic testing reveals about 40 to 50% of cases come up with, a positive yield of mutations. So it might be worthwhile, but only after thoroughly taking the 3-generational history and, investigating him thoroughly, then I think it might be worthwhile to do if they're also willing to do some genetic counseling has to be done first about what the test is all about and what to expect out of the test, and then if they're willing to proceed with the test, more than whether it will help in clinical, there won't be any management difference as far as this patient is concerned, but there's a good chance that if a positive mutation is identified, pathogenic mutation is identified, then it might make sense to do the particular targeted sequencing in his first degree family members, like his children, his other siblings, and also to prophylactically follow them up, to prevent any sudden cardiac death. So this would be my approach in terms of the genetic aspect.
Ma'am, just one follow-up question to that. Is there any genetic sequence we can do on this patient that will identify this index case as a high risk for arrhythmia? Is there something that we can do in genetics?
See, there are some studies which say that some particular sarcomeric genes are more are capable of worse prognosis than others. So that's like the MYBP, but it's not very clear. So there's some controversy as to thick filament, thin filament, and all of that. But if something actually comes up, again, ICD, it's something which is very, very clinically based. The criteria for ICD are very clinical rather than genetic. So it's more phenotype based than genotype at this point in time. But it will help to cascade screen the immediate family members. I think that is where the main role of genetic testing at this age for this individual's family would be.
Perfect. Thank you so much. So I think that two things that came out of the discussion was that this guy is low risk for arrhythmia, and certainly we should not be delving too much into ICD at this time, but few evaluations we can do to further risk stratify. Holter was suggested as one, MRI was suggested as another, and maybe a TMT was suggested as a third one. So Praneeth, walk us through what all you did for this patient. Just give us the findings, and then maybe we can further our discussion on this patient.
Yeah. So I did not subject him to treadmill. I asked him for a Holter. Initially, in-house 24-hour Holter was done, followed by a 72-hour Holter was done in this patient.
And Praneeth, just share us the findings of that, and also if anything else you did, and then we'll ask others for their opinion.
Yeah, so to tell you about the 72-hour Holter which we did, so patient, I'll just read the comments which was at the end of that 72-hour Holter. The patient's predominant rhythm was sinus rhythm. Ventricular ectopic beats were noted in single, pair, and run forms. Supraventricular ectopic beats were noted in single and run forms, and no patient-triggered events were documented. And in this ventricular ectopy, he had total about 1056 ectopics, and he had runs of VT with the longest run of 13 beats with a heart with a rate of 177, and the fastest run were with the 3 beats with a rate of 186 beats per minute. So this was the Holter report, 72-hour Holter of this patient.
And the MRI?
So this was followed by a cardiac MRI. I'm sure Dr. Johann will give his inputs. So I'll again read the final diagnosis of cardiac MRI. So it's an apical hypertrophic cardiomyopathy. The LV mass was 187 grams and the scar mass was 45 grams with a scar percentage of 24%. There is a patchy mid-myocardial delayed enhancement in the basal and mid-septum and apex, not conforming to any coronary artery.
Okay, so we have two extra information. Episode of non-sustained VT lasting for 13 beats maximum. Again, not something to be too crazy about, but that is one additional finding. And then an cardiac MRI with some fibrosis. Dr. Johann, I'm going to bring you in here. I'm unmuting you. You heard the clinical case. There are two extra findings. There is one cardiac MRI finding. How do you tie up this together? And would you be willing to put ICD in this patient now?
Yes, Anup, thank you once again for the invitation. And since there is so much interest in the MRI, I'll just take a minute, Anup, to just give us the context of how MRI is useful in this situation. So we all understand that echocardiography is the primary modality. It is the technique to be used in all cases of HCM, the technique in fact. However, because it is operator dependent and there is an acoustic window issue, two areas are not that well depicted. That is the anterolateral free wall and the apex. Now, especially in apical HCM, and this is my personal experience, we have had a number of patients with a classic ECG who have been referred via an echo being normal. And then we have done the MRI and we have found the classical apical HCM, which basically means in MRI terms that you have an apex which is more than 15 mm. This is MRI definitions. And the apical wall to basal wall, there's a ratio of more than 1.5:1. And you get a classical spade-like configuration of the LV cavity at end diastole, which is really best seen in the vertical long axis view in MR terms or in a two-chamber view in echo terms. So this is basically how we make this diagnosis. And echo has a lot of false negatives, especially in this area. So MRI gives you the diagnosis, number one. Number two is that the ability to look at the wall thickness, which you yourself said was a very important measure for sudden cardiac death or one of the risk factors, is very good because the blood pool myocardial layer differentiation is excellent in MRI. The spatial resolution is excellent. So you really get the accurate wall thickness compared to what you would get with echo. So a good wall thickness, and we have varying definitions. So more than 30 obviously is extremely high risk. But by the very definition of hypertrophic cardiomyopathy, what is the issue is really not the hypertrophy, but the arrangement of muscle. That's the disarray. And that is certainly extremely well picked up with MRT due to its tissue characterization. So much so with the data that is available, especially with Dr. Marin's group and Dr. Chan's group, is that they have a lot of evidence to say that irrespective of the absence or presence of some of the other factors, a significant gadolinium enhancement, which again in layman terms means more the fibrosis, more the volume of distribution, and more LG gets stuck and the LG comes out later. So we have a way of picking that LG in transit, and we are able to now with good software quantify. And the number that has come out with two studies, which was done in about 4 years ago by Dr. Marin's group, is 15%. Well, although it is arbitrary, in about 1,300 patients, this seemed to have a linear correlation with sudden cardiac death, irrespective of whatever other parameter that you chose, whether you chose obstruction, whether you chose asymmetric hypertrophy or apical. So LG seems to be a very important component when you're looking at adding those items to making a cause for having a higher risk of sudden cardiac death, or for that matter, planning for an ICD. Now, based on this MR, we have found, and Praneeth is given that number of 24%. Our lab is 15% and above. This is based again, as I said, on Dr. Marin's criteria. So when you have a gadolinium enhancement of more than 15% of the myocardium, and here it is 24%, this patient suddenly moves from what we are taught about the three risk groups, that is the low risk, intermediate, and the high risk group. This is the data that is again, I think, I'm not mistaken, again, it's Dr. Marin's group which has looked at it. You suddenly move from the lowest risk, which is apical HCM, without an obstruction. And I'm not sure whether I mentioned the apical thickness, Praneeth, on that report, but generally we do mention that. We also talk about a obliteration index. I think it's on that report. So we're basically moving this patient from the lowest risk to a fairly high risk based on whatever data you have. So Anup, this is my take on this particular patient.
So Dr. Johann, like while your expertise is on cardiac imaging like MRI and CT, if you see this patient, you have got this all clinical information now with you. The question to you is ICD or no ICD? 62-year-old guy who so far did not have any event.
Yeah.
Clinical low risk.
Yeah. So, I mean, if you just look at the three groups, as I said, that we now have of this stratification, he certainly comes off clinically into the lowest group because he does not have an aneurysm, he does not have LV obstruction, and we're really not sure about any other history. And the Holter, I believe, whatever Praneeth said, did not have any kind of sort of a poor prognostic feature. We have not done the treadmill, obviously. The family history, as everybody agreed, is a little iffy because it's a second degree relative, although we do see those things happening. And the LVH is obviously not massive. So on the face of it, it comes as the lowest degree. But when you add gadolinium to it, the 24%, it is a number which certainly will allow me to move him from the lowest to the intermediate. What I would do, and this is just a personal choice, because of his age, would do a CT angio and also check what his coronary artery status is, because 62 we know that CAD sort of comes in, and this will also be a point wherein I'm going to look for things where like myocardial bridging, or if there's any deep bridge of the myocardium of the coronary vessels. So that will again add to my assessment of this patient. So if he has no coronary artery disease or mild, he has only an apical HCM, although the gadolinium is there, I would possibly talk to the family. I will take the assistance of genetic help, because again, if I have a genetic marker, as Priya has said, which is a high-risk genetic marker, then this is going to be something that is going to pushing me to counsel this patient and maybe take a second opinion, a shared opinion to whether this guy would actually benefit from an ICD. So I would keep it open.
Perfect. Thank you so much, sir. I think at this point we have got some information to talk about. So I will open the discussion.
Praneeth, could you please give a little more details on MRI? See, at the echo, it was an apical HCM. Was the MRI also, it was only an apical, or it is something else?
Praneeth, if you could just read out the echo report, please. Sorry, the MRI report, please.
Yeah, it is apical, sir. So it is apical hypertrophic cardiomyopathy with scarring. No LVOT obstruction, no SAM, mild MR.
So where was the scarring? Only in the apex or throughout the LV?
Basal, mid-septum, and apex. These are the areas mentioned, sir. Not conforming to any coronary territory.
It's true, but it is not confined to the apex, right? It is actually going beyond the areas where echo had found a hypertrophy. Am I right?
Yes.
Yeah.
One more clarification. Just want to know what was the apical thickness. I generally usually measure that.
It's not there, sir. Apical thickness is not mentioned. I can see obliteration index
Yeah, just talk
And
about the
just
obliteration index. Can you just tell us the obliteration index? Because I usually put
0.7.
Yeah. So just one clarification, Anup. We put in something called an obliteration index, which is basically we look at the septal thickness, the apical thickness, and we look at the thickness of the cavity, the cavity thickness, the cavity size, and we look at the apical thickness. And anything more than 0.5, this is an MRI parameter, puts these patients again at high risk for arrhythmias. More atrial, especially if they are apical, but also ventricular arrhythmias. So anything above 0.5 is something that puts these patients at little higher risk. So the obliteration index is also sort of gearing this patient to a higher risk.
Now, was the LV dilated, or what are the dimensions on MRI of the LV? Was it, Johann, is it looking dilated based on the report?
So the LV size is normal. EDD 41 millimeters, interventricular septum 14 millimeters, 1.4. I'm looking at the numbers, none of it suggests dilatation. LV mass is increased, but there is no dilatation.
Okay.
So, Dr. Hygriv, this is, again, these are imaging criteria. They are all sitting there. And I think for us also, clinically going forward, doing a Holter and MRI only made sense. We also had a very high threshold of putting ICD for the reasons that are discussed already. Now we have got these two pieces of information. One is Holter with no VT for sure, but a few runs of non-sustained VT, asymptomatic. And this cardiac MRI finding, which for whatever face value of it, we take it. Of course, at the end of the day, we are making clinical decisions. We have not made a decision for this patient yet. So how would you unfold this? Do we need to do something else, or we are just beating around the bush? This patient does not need an ICD. Dr. Hygriv, what would you think?
Yeah, it's a great findings. Now we have moved away from the clinical judgment, and actually, if you notice Dr. Johann's presentation while he was talking, there's a lot of hesitation in boldly saying what he wanted to say. What is quite right. Basically, there's a lot of what I should say, the gray area now between the clinical guidelines and the clinical practice after the cardiac MRI has come in. Now, we too are doing a lot of, we rely a lot on cardiac MRI these days for many reasons. And the findings of the cardiac MRI bring out a lot of points that are described about how come. Now, first thing is, apical HCM was considered as a low risk, as he has rightly said. That was because it was thought that it was a localized hypertrophic cardiomyopathy and not otherwise. But the clinical outcomes of these were described as if the HCM was no different from the rest of the HCM. And that's quite rightly shown by this MRI. As you can see that there is a scarring not limited to the apex, but beyond the areas which are noticed by the echocardiogram, showing that actually this is in fact really either a truly a HCM like the clinical HCM that we see, or we are looking at some other causes of scarring to explain, because the scarring is very impressive. It's very extensive in this particular patient, and it is disproportionate to the echo findings. So but one needs to remember that these days we definitely know only three clinical syndromes, that is a coronary ischemic cardiomyopathy, dilated, and a hypertrophic. But in reality, there are so many subsets that we are not aware. With cardiac MRI, they are coming forth, which are substrates for sudden cardiac death. So now, having said that, now we have a patient with a non-sustained ventricular tachycardia, significant scarring, and absolutely no symptoms as such. Now, there is not much point in doing EP study for this patient, because when you have such a large scar and you have NSVT, invariably you induce a ventricular tachycardia. You can as well say that this patient will have a sustained VT. So now, certainly, the clinical guidelines wise, now this is where the discrepancy comes, and that is where this good program is there. Clinical guidelines wise, this patient does not fall into a candidate for ICD. because if you see, he doesn't have any of the factors which guidelines have described. But because cardiac MRI has unfortunately not come into the guidelines for decision making, it is there in the guidelines for diagnosis, but not in decision making. Now, in a patient with such a huge scar with a non-sustained ventricular tachycardia, I would certainly be concerned about the risk of sudden cardiac death. Certainly, we would go a step ahead and counsel the patient family for the benefits of ICD in this patient.
Perfect. Thank you so much, sir. I'm again inviting discussion from my audience. I'm going to pick few names about how you would go with this patient. Dr. Vamsi Krishna, I'm unmuting you. I hope you heard the entire clinical discussion. This patient is in front of you. You need to make a decision, ICD or no ICD. Would you do something else apart from what we discussed? Dr. Vamsi.
Sir, good evening, sir. Sir, good evening, sir. Sir, as I go through the case history, sir, the patient falls into the low risk category in relation to sudden cardiac death, sir. So far, no extra investigations may be needed except for genetic testing if needed to further delineate if the patient is having high risk of sudden cardiac death, sir. History and evaluation, maybe as sir was telling, maybe he should be counseled for ICD to prevent sudden cardiac death after seeing the MRI, sir. Without MRI, maybe with the Holter and echocardiography, we will be falling into low risk category and he may not require, sir. But after seeing the MRI report, maybe we should have to think of ICD, sir. That is my opinion, sir.
Perfect. Thank you so much. Dr. Praveen, I'm going to bring you back in here. You asked for MRI and Holter. You have both the information now. How does that change your thought process for this patient?
Sir, seeing the Holter runs of NSVT and the cardiac MRI showing 24% of scar burden, I would go for ICD, sir.
You'll go for ICD for this patient. So, yes. Okay, that is good. Anybody else has got any other thoughts about this case? I have a few questions for Dr. Hygriv and Dr. Priya, but before that, if anybody else has any other points to add to this case?
We had not talked much about, actually, now that Priya is there, we must take advantage of her presence. Now, what we understand from genetics is not so much in HCM. One of the things is it's autosomal dominant condition with variable penetrance. So as such, the presence of a gene itself, and second thing is there's so many other, it's not a single, so many genes have been identified, and I am not aware that any gene is correlated strongly with sudden cardiac death. That would have actually made things very easier. That is not the case. The purpose of genetics is more to rule, exclude the other phenocopies. For example, there are which we don't diagnose. We just diagnose its hypertrophy, and it could be amyloidosis, Pompe's disease, Andersen-Fabry's disease, myotonic dystrophy, and so forth. It's more to rule out these phenocopy conditions that genetics has been generally used in the past. I'm not aware of a sudden cardiac death decision making being helped by genetics. I would like Priya to comment on this.
Yeah, you're quite right, Dr. Hygriv. So, yes, I was just looking up. So, I mean, I think last few years, more than, I'm sure, though there's 30, 40 genes, I think even 50, 60 genes have been implicated. But after all the filtering out, so about 8 to 10 of them are now definitive, genes underlying HCM that if identified, if a mutation is identified in those 8 to 10 genes, then they are very much in the moved from the likely pathogenic or other categories to the definite pathogenic variant. So the myosin binding, there's the MYBPC3, the MYH7, and troponin, tropomyosin. So these are some of the few of the 8 to 10 genes that I'm just talking about. And then, as you said, the phenocopy. So that's again, the presentation would have been in at much younger age, and of course, we're talking about the Pompe's and other metabolic conditions or even the rasopathies as are coming up as differentials for this. But again, there the presentation would have been more severe and probably at a younger age. So this seems to be an case where, again, as you said, sudden cardiac death cannot be, there's no clear indication as to say thick filament, thin filament mutation. So lots of work is going on, but it's not as clear cut as in some channelopathies. We know very clearly that if there is this particular mutation, then there is a high chance that, the stratification immediately it goes higher. So that's not the case in HCM so far. So as we discussed, I think the role of genetic testing here is to identify, yes, if it's autosomal dominant, yes, many of them could in the family have had some presentation or manifestation without that being very obvious, or it's just that many of our Indian families are not aware or they keep it to themselves. Quite often it's not like very disclosed. So it's a customer. I think it's also a tradition or what to say, a belief that some things will not be shared. So that's the reason why we have a bottleneck even with family screening and cascade screening in our Indian families, right? So it's not easy to convince. And of course, we also know that the repercussions of a diagnosis such as HCM could be quite a bit. Again, it's more in the West that they have implications with their insurance, with their employability and other things, but not so much here. But again, it's the stigma that of a diagnosis that is should be considered in a condition like ours, in a country like ours. So the short answer is yes. There's no clear-cut connection between the genotype and the risk for sudden cardiac death, but it might just throw better clarity and help us to definitely diagnose other family members if this particular patient has a genetic mutation.
Ma'am, I'll ask you one question on the same front, because genetic testing or as a general knowledge about genetic testing amongst cardiologists, like we are not really expert at it. If you could just for 2 minutes guide us about when we have cases like these, how do we go about genetic testing in that index case? So we talked about counseling, we talked about the implications, but how do we actually test for them? Like, are there designated labs that do it, and what should we be ordering? So if you could just shed some light on it.
Sure, Dr. Anup. So the trend, or I think it's been revolutionized basically by the next generation sequencing. So NGS is something which is a new development in genetics. So instead of the conventional genetic testing or the sequencing, which is time consuming and more expensive, and also only looks at one particular gene at a point in time. That was how it was done earlier on. But I think from the last decade or so, we have something called the NGS, the next generation sequencing, where you're able to look at multiple genes. So if we say the top 10 suspects for HCM are these genes, then that can specifically look at those 8 to 10 genes or 12 genes, and it's done much faster. The turnaround time is so fast, like within a couple of weeks, 1 week or so, we get the information. But of course, it depends on whether it's being done as a specific patient is being genotyped alone, or if it's being done as part of a study, because then they have to wait for more samples to be collected and all that. But in general, the price has also come down. So for an NGS for this particular patient with the apical HCM, you would be looking at those 8 to 10, those highly possible diagnostic genes, and then the cost would be somewhere around 15 to 20,000. So that would be for the index patient. And once it is identified, let's say he shows up a MYH7 positivity, a gene or something like that, then it's going to be a targeted genetic sequencing in the first degree family members. So his siblings or his children would need to undergo that test, and that cost comes down dramatically to less than 5,000 per because it's just going to be a particular gene that they're going to look for. And yeah, so it could be, I think, less than 5,000. I'm not sure of the exact numbers, but somewhere between 3,000 and 5,000. So this is what the genetic testing at the moment is. So if nothing comes up again, if we're really sure, but again, the family history plays a key role here. So if there are more members in the family that we can identify with a thorough genetic testing, it might make sense to even send in the samples of those family members. Or if the echocardiogram of the sister, his sister's son expired, right? So if either that sister or somebody else, other siblings in that particular family have echocardiographic evidence of HCM, then it might make sense to even send in a couple more samples. So at the moment, private labs are doing these NGSs. So just to name a few, MedGenome, Strand, and all a few labs with whom we have experience with them, their results are good and reliable. So yeah, I think that's, hope I've answered your question.
So ma'am, we can simply just write this order that please do NGS for apical hypertrophy. Is that the correct way?
Yeah, so you have to give the clinical picture of HCM. In fact, the geneticist or somebody from that's, their team would be able to come in, have quick genetic counseling with the family or the patient, and then take it forward. So that's how it is done. So you need to give the clinical picture to them and let them know that you're looking for a HCM panel, and that's I think that's how it goes. So they get the phenotype, document the phenotype, and genetic counseling needs to be done by somebody, preferably from their end, if they can send somebody, or if there's somebody at. I used to come to Care Hospital a couple of years ago on a regular basis and used to run these cardiogenetic clinics. But however, due to some change and everything, that has not been continued. In fact, we recently submitted the data for publication. So what came out clearly was these cardiogenetic clinics are very helpful because they collect all the suspected channelopathies, cardiomyopathies cases, and we used to counsel them, talk to them as a team. And then that was done as a research study. So it was actually free of cost for the patients. But however, that's not sustainable, right? So I think that study ended some time ago. But yes, it should be discussed with the genetic expert at the end of lab's end, and then they would do the necessary to do the sampling and, if possible, the counseling as well. Test counseling for the patient and the family.
Perfect. Thank you so much, ma'am. Dr. Sriran, your hand is up. Do you have any questions? I'm unmuting you. Dr. Sriran, please go ahead.
Am I audible?
Yes, sir, you're audible.
Yeah, I just wanted to know the role of medical management short of an ICD, and what are the kind of drugs we would generally avoid in patients with HCM.
Perfect. I think that so that question was part of my question to be asked to Dr. Hygriv. So Dr. Hygriv, I'm going to bring you here. So risk reduction strategies other than ICD in this particular patient, is there anything that you can add or you can avoid to reduce the risk? I'm unmuting you now.
Yeah.
Dr. Hygriv.
See, classically and traditionally, we are taught that when you have an hypertrophic cardiomyopathy, you use a negative inotropic drugs like calcium channel blockers to reduce the gradient. That is what is generally practiced. But with the advent of scars, we are realizing one thing. There is a common pathway to sudden death when we, with the advent of cardiac MRI, that we realized. The common pathway of dying of a patient is due to the re-entry arrhythmias around large scars. So that is common, whether you talk of a sarcoid fibrosis, a hypertrophic cardiomyopathy fibrosis, a DCM, or even a coronary artery disease. Only the pattern differs. And it is very clearly shown that if you use a beta blockers to the maximally tolerated, like all heart failure patients, there is a good chance that you prevent these re-entry arrhythmias, because you are going to slow down the re-entry circuits. And even if an ectopic enters into re-entry circuit, it is to become a malignant ventricular arrhythmia. So a large, see, as I said, it is not, we are already not taken granted for ICD because it is not according to the guidelines, and this MRI is not uniformly available, and neither it is done for every patient. Your patient could have easily escaped in many hospitals not doing anything apart from management of COVID. If only with the advent of MRI, we have so much information. So it is follows that antiarrhythmics like amiodarone are not indicated as a prophylactic measure clearly, but you have because the the side effects and the negative aspects overweigh the benefits. On the contrary, a beta blockers to the maximal tolerated doses certainly reduce the ventricular arrhythmias and sudden death in this patient.
Perfect. Thank you so much, sir. We have about 2-3 more minutes. Anybody has got any other questions or comments for this session? I'm just going to keep it open for anyone to chip in.
Anup, some comment on a genetic which you I know, because I am as much a confused cardiologist as you are with respect to genetics. I could understand that, and since the last 10 or 12 years, we've been trying to get this genetics into the into an armamentarium. It's basically the genetics assessment is on the other side of the fence, and cardiology, clinical cardiology is this side of the fence. Now, what I'll exactly address your question the way how a clinician wants. See, like any other diagnostic test, like a blood sugar or anything, a clinician would want a genetic test, somebody to take a sample and pick up a gene and say, yes, this patient has this disease. Unfortunately, the way genetics in cardiology of sudden death has grown, that is not the way it works. The reason is the following. A single disease has many, many genes, and more are, as you explore and as you investigate, more and more genes are identified in each disease. It is not just HCM, that the same goes with LQT and so on and so forth. The number of genes increase. So there is no single gene, first of all, to diagnose a disease. So if you go without a clinical assessment of a patient directly for genetic testing, it is of no use. And the second thing we also have found in our own research paper is that there seems to be some common pathway of sudden cardiac death and ventricular arrhythmias also. That means different substrates for sudden death, like ischemic heart disease, CAR-VT. Surprisingly, they have genes which identify LQT and CPVT, and surprisingly, very surprisingly. So you can find the same genes in that patient and multiple genes in a single patient. So to answering your question, it has not evolved to a situation where you can just draw a blood and give out. You need to do a lot of work, clinical work, make a very, very definitive diagnosis and ask a specific question. And you need to find out whether that gene has been correlated with this particular thing you're looking for. For example, your patient, there is no gene that is coding for sudden death that has been recognized. So there's no advantage in you getting a gene testing to make a clinical decision making. So that is where I just wanted to summarize the cardiologist perspective of how genetics stands as on today.
Absolutely, sir. I think that is very relevant to our discussion, and certainly one of the take-home points that you can't just order a gene to decide whether this guy needs an ICD or not. But the role of genetic testing is, of course, established, as Dr. Priya was saying, in terms of index case identification as well as screening the family. 1 more minute. Anybody else has got any other thoughts or questions? I'm just going to read a few questions.
Anup, I have a comment.
Yes, Johann, sir, please go ahead.
Anup, yeah.
Yes, Johann, sir, please go ahead.
Continuation of what we were discussing, HCM is a very diverse, very heterogeneous spectrum of diseases. So it does not have a one-size-fit-all specific gene, specific imaging study. So that's the reason why we have a constellation of risk factors, just like we have an ARVD, multiple things that need to be ticked off before you can actually make that decision. And we know that the decision is complex. But what has clearly come out is that if you just look at the data that is emerging, one of the important tools that helps us make the decision or assists us is the MRI, simply because you get a better diagnosis. Because we know that there are variants of HCM apart from the classical IVS, the classical obstructive or the apical. We have the isolated heterogeneous type where we find masses of muscle along different walls which cannot be seen by the echo. So making the diagnosis very important, proving the disarray, which is part of the ventricular arrhythmia pattern. The disarray basically means that there is fibrosis and that there is increased volume of distribution by gadolinium. And we are even moving forward by doing something called T1 mapping, which I mentioned last time, where we find that gadolinium actually is less sensitive, and the T1 mapping is now going to throw more light into other areas. In fact, this is classically seen in the present patient, while most of the apical HCMs that are imaged have a scar exclusively in the apex. But this patient has something which is moving towards the base. And we are going to see more of this in T1 mapping. And not only the presence of the gadolinium, but now we have moved to a stage where we're able to quantify it. And the quantification seems to be making the difference, because the earlier studies where presence or absence of gadolinium were used had no relevance to mortality. But once we started quantitating, we realized, and we came to this figure of 15%, that once you cross this threshold, the chance of sudden cardiac death almost doubled. So I think we're moving towards a more quantitative parametric, both in terms of late cardiac enhancement, and the T1 is going to make us even more better in helping us stratify these patients. Not the perfect tool, but it will be one of the important tools. Thank you.
Perfect. Thank you so much, sir. I think we are running out of time. I'm just going to quickly read through some of the questions. Now, I won't be discussing a lot of these questions because they are very generic for today's discussion. Like medical management of hypertrophic cardiomyopathy, I don't think we can do justice on this forum with 1 hour. Is there any cure for hypertrophic cardiomyopathy? Unfortunately not. It's a genetic disease, is sitting there. There were few questions about few gene mutation as a risk factor for sudden cardiac death. That has been addressed already by Dr. Priya and Dr. Hygriv, that there are gene mutations which have been studied, but none of them have been in the prime time. So I don't think at this point of time we can do any genetic test that can identify a high risk for sudden cardiac death. There is one last question that I'm going to have Dr. Hygriv answer, if you could please. The question is, disopyramide is not easily available that frequently. So what would be the alternative other than the traditional calcium channel blocker and beta blocker when disopyramide is not available? Dr. Hygriv.
True. We had this problem in the last 2-3 years, and somehow people could procure it. I do not know by what means, but now again it is becoming available relatively better than last few years. But having said that, if we do not have an arrhythmia, very clear. If we do not have an arrhythmia like this patient, beta blockers alone would be good enough. And if you have a LVOT obstruction, significant LVOT obstruction, calcium channel blockers, verapamil would be the first choice. And if you have a ventricular tachycardia and arrhythmia, amiodarone plus beta blockers are the best combination.
Perfect. Thank you so much, sir. We would like to close the session. Dr. Priya, you joined us for the first time. If you could just give us your closing comments on the session as a general, maybe a little bit on the topic, but more as a session format. What did you think and how can we improve on it? Dr. Priya, 30 seconds.
Yeah, thanks Anup for having me first and foremost. I really enjoyed this case-based discussion. It was very well organized, well conducted, and I think it's a great way moving forward to have these kind of specific case-specific discussions so that we have thoughts and feedback or suggestions from all those who are seeing similar patients, and this should be extended into several facets of cardiology. So good luck with that, and I would love to join in further sessions as well.
Thank you, ma'am. Dr. Hygriv, this is your second session joining us. Any constructive criticism about the session?
Yeah. So no, it's a very good. It's a clinical decision-making session. So the way it is done, actually, it is very useful for training postgraduates. And I know you have been putting into the CSI. I think more people should contribute, and it will become a nice forum to clinical decision making. And people can even put up their cases instead of you putting up every time, and even can go for a general discussion on how to manage this patient. It's a great beginning.
Thank you, sir. Dr. Johann, your closing comments for the session, please.
Yeah, am I audible?
Yes, sir. Yes, sir, you are audible.
Yeah.
Please go ahead.
Yeah, just once again, thank you, Anup, and I've been really enjoyed the sessions. Thank you also for Priya for accepting at a very short notice our invitation. In fact, we invited over for our CSI Telangana meet last year. So thanks for that. And Hygriv and I always keep meeting either virtually or not. So I think it was very enjoyable. And I think it is important that although we work in very different circumstances in different areas, we are able to bring to the table and add value to whatever is already available. I think that's the greatest gift that we all bring. Thank you.
Thank you so much, sir. Praneeth, your closing comments, and then we are done.
Yeah, so just to complete the case scenario, I counseled the family about the requirement of ICD to prevent SCD, getting the inputs from both Dr. Johann and Dr. Anup. So he listened to the story and understood, and he said he needs some time to think over and he'll get back. Regarding treatment, he was already on beta blocker, metoprolol succinate 25 milligrams. In view of those non-sustained VTs and short runs of VT, I did also add him on amiodarone. He's on follow-up, currently doing good. And this is about the case. And to conclude, I would firstly thank the. Hello, am I audible?
Yes, Praneeth.
Yeah. So firstly, I would like to thank the guests of honor, the Dr. Johann, Dr. Hygriv, and Dr. I am getting a call. Sorry, Dr. Priya. Yeah, sorry. So thank you all, and equally I also thank the participants for their valuable comments. It was really a good discussion, lot of things to learn, and I hope that we'll be having these discussions many more in the future. Thank you all.
Thank you, Praneeth, and thank you all of you for attending today's session. Special thanks to my guests joining today. The weekly huddle is hosted every Wednesday at 7:30 p.m. So this is today's time. The link to join the session, the ID, password, all are static. So if you have any invitation, you can use it for future sessions. You really don't need a new link or a new ID. They are all statics. And all the huddle sessions are recorded. Recording these are available on podcast and YouTube. You can simply just search the weekly huddle on either one of the two. And if you're interested for any particular recording, you can just email me. I will be able to send it to you. I thank you all again for your time participating in the discussion. Good night and see you again next week, same time. Good night, guys.